Coronavirus exists. Coronavirus is a disease that attacks the respiratory system. The symptoms of COVID-19 are fever, tiredness, dry cough, shortness of breath, headache, sore throat. Coronavirus spreads primarily through droplets of saliva or discharge from the nose when an infected person coughs or sneezes. Please don't be scared. To prevent infection and to slow transmission of COVID-19, follow the safety precautionary measures placed by the World Health Organization. Wash your hands regularly with soap and water, or clean them with alcohol-based hand rubs. Maintain at least 1 meter distance between you and people coughing or sneezing. Avoid touching your face. Cover your mouth and nose when coughing or sneezing. Stay home if you feel unwell. Refrain from smoking and other activities that weaken the lungs. Practice physical distancing by avoiding unnecessary travel and stay away from large groups of people. Please don't be scared of the virus. Follow the precautionary measures. Stay home, stay safe.
Thank you very much. Distinguished Honorable Speaker, distinguished Honorable Members of the National Assembly, we are indeed very grateful for this opportunity to come before you once again to chart the way forward for our nation together. We are always grateful for the frank discussions that are held in this August Assembly, as we always leave with better plans and ideas for the development of this country. It is like a refinery of ideas. I have listened very keenly to all the interventions, and we are grateful for them. We will endeavor to look into each one of them. They are all very important. Thus, kindly bear with us. We've also taken note of the special committee's findings and recommendations, and will endeavor to make sure that we register improvements on all of them. This is a very important period in our existence as a country. We have patiently listened, as I mentioned, to all the deliberations, and it has enriched us greatly. By way of giving you the general overview, globally since the 31st December 2019 and as of 15th May 2020, a total of 24,338,658 cases of COVID-19, in accordance with the applied case definitions in the affected countries, have been reported. Of these, 297,119 deaths were registered. Africa has registered 54,190 confirmed cases, with 1,623 deaths registered so far. Senegal, our closest neighbor, has registered a total of 2,189, with a total fatality of 23. The Gambia, as of yesterday, has registered 23 cases with 1 death. We've been carrying out a lot of contact tracing in this country. Contact tracing is the cornerstone of the response in the prevention and containment stages. At first, all attempts were geared towards following people who had returned from hotspot countries. This is before quarantine started. These people of interest were asked to home isolate and were followed routinely by health personnel for the development of symptoms. Those who developed symptoms were tested. Of those people, 350 were followed for 14 days. Now, the contact tracing is concentrated on following the contacts of the confirmed cases and the contacts of contacts. Once the high-risk contacts are identified, they are quarantined, and the low-risk cases are followed at home for 2 weeks. The target for contact tracing is 790, and 789 have been traced successfully. Of the low risk being followed, 105 were the total, and out of that, we went beyond to have followed 109 cases. The quarantine. Quarantine was started in early March 2020. Initially, it started with people traveling into the country from hotspot countries, hotspot zones. Initially, this was shrouded with challenges as many of the people were not cooperating. Quarantine is one of the interventions that has yielded so much dividend in the Gambia. Most of our positive cases, in fact, 76.9%, were all confirmed whilst undergoing quarantine. That means the risk of their association with the people when they became positive, when they started shedding the virus, was very low because they were already in quarantine. That means that they would have been identified by the contact tracing team and be kept under our watchful eyes. We were on our own able to start testing for those people in quarantine before discharge. This was not in any recommendation or guideline when we started, but it has turned out to be a very great intervention, and as we speak here, many countries have adopted that. We started here in this Gambia even well before the WHO recommended it, because we thought it made sense, because there was a period at which people start shedding the virus, and that is when the virus can be obtained for a positive test. Before then, they would not be positive. So we thought it was important to test anybody who had undergone quarantine before they were discharged, and many countries are following suit now. Of course, as we mentioned, this might be because if one tests early, those contacts, before they start shedding the virus, they will initially be negative, when the reality actually is that they are in fact positive. This has prevented many infected people being discharged into the community. This, however, is very expensive. It's a very expensive intervention, but it is one that has yielded dividend. As I mentioned earlier, 23 confirmed cases. Out of those, 17 were diagnosed whilst in quarantine. Currently, we have 94 people in quarantine, and 375 have completed the quarantine as we speak. I'm happy to know that both the Special Committee and the Health Select Committee had visited the quarantine sites. These are hotels with great services. Our health personnel and security officers also are present in those centers 24 hours to ensure the health and security needs are addressed. We have tried to make it as comfortable as possible for the people in quarantine, but of course, unfortunately, it can never replace their homes. So occasionally you see complaints on the media, but they have been taken very, very, very good care of. The average room has a television, an air conditioner, and even internet facilities. We have received a lot of commendation from people who leave our facilities, but of course a few concerns have been raised, and certainly few people will never be satisfied with whatever is given to them. But at this juncture, I think as a country, we have tried very hard because we have seen big countries in Africa. I'll mention two examples. One of them took people to a quarantine center when they came from overseas and asked them to pay for themselves and left them there. Another big country took them to a quarantine center and asked people to pay. When they made noise, they took them out, took them to a primary school, left them there, threw mattresses at them, and then said it was their business and put security forces. Of course, Gambia, we never dream of that, so we have done our best to give our people a dignified treatment. As at present, we have spent more than $20 million in quarantine facilities. This will go up if we are still in the containment stage. If we are unlucky to slip into the mitigation stage where there are so many community transmissions that we do not even know the source of those transmissions at that point, because it could be so overwhelming that you don't know now who gave it to who. Then the strategy will be home isolation of infected and suspected cases. And we know how difficult that is in our communities, where we all live together, as had been mentioned by previous honorable members, speakers here. We live together, we eat together. Home isolation is easier for communities in the West, many of who were already isolated by their natural way of living. But it is very difficult for us in this country because our natural way of living is socialization. At present, our containment stage is going on well, as we almost know the epidemiological link of almost all the cases, and all non-contacts have been traced and tested. Coming to testing, testing is the cornerstone of this response. The recommended testing level is now at least 2% of the population, Honorable. The countries that have done a lot of testing have tested between 40 to 60,000 per million people. After this crisis, if we had 30,000 tested, we would have been in that range. But we want to go a little beyond that because of the way we live together here in our communities. As an example, India has tested 1,480 per million. That's what India has tested because of their population. And that is far below what the recommended total number is. The country that has done the highest number of tests so far is Portugal, and they have done 58,827 per million population. As at now, the Gambia has conducted 1,440 tests and have confirmed 23 positive test results. That means as at now, we are doing about 700 tests per million people. The case definition has been widened now. That means there is some modification as to what cases should be tested. So the case definition being widened to include all cases with symptoms of fever or cough and one other symptom. These are the people who need to be tested. Travel history and history of contact, which used to be part of the case definition, are no longer considered necessary in the definition of what we call a suspected case. This, therefore, will lead to an increase in the number of people to be tested and isolated. However, testing without symptoms is not recommended except for health workers who are involved in the management of these patients. But as we see, recommendations are there but countries are supposed to take the recommendations and adapt based on their national realities. The way our markets are, the way our ferries are, the way our fishing ports are, is giving us more ideas to go into those highly densely populated areas to test more and more people. And this is the plan of the ministry. As of now, we are using PCR testing in MRC Fajara, and we are happy to inform the honorable members here that our Kotru National Public Health Laboratory is ready, and they'll start doing the testing, inshallah, next week. MRC Gambia is also extending the testing sites to Keneba and Basse so that people do not have to come all the way down here to get tested. We are also hoping that once the Gene Expert cartridge is available to developing countries, we can have 6 other sites tested. We have Gene Expert machines, but the machines are locked by the manufacturers. That's the way they do their business. Now, cartridges have been manufactured specifically for COVID-19, but they have not been made available to developing countries yet. We learned that one big country has decided for them not to be exported. When that export ban is lifted, we hope to get these machines, and that means we can do more testing because the test becomes less dangerous for the laboratory staff then, and it can be done at more sites. We have 6 Gene Expert machines across the length and breadth of this country. Risk communication is ongoing. A lot of work has been done on the radio, on the TV, billboards, posters have been circulated. We've been having daily media briefings by the ministry, myself, and the entire team to help sensitize people, to communicate to the people, to give them the updates. This has been ongoing, and certainly the role the honorable members played in the sensitization has been remarkable, because a lot of communities that we visited, you had visited them before we got there, when I went to up-country recently, and most of those communities have attested to the information being shared to them. We want to use the opportunity to thank you very much. However, honorable members, Madam Speaker, distinguished honorable members, we are very concerned with the rate of false information in our communities, especially the use of WhatsApp messages. False information has been very detrimental to our collective efforts to fight COVID-19. They range from all sources. People scaring people, people talking about immunization that is not true. This has a detrimental effect because now, as mentioned by one honorable member, I think of Talinding, women are scared to take their children for routine immunization. That means COVID could be over, and we in our communities experience outbreaks of measles, yellow fever, tuberculosis, and other diseases just because women were afraid to take their people for vaccination. And we appeal to the honorable members to help advocate against this practice. Isolation centers. There are 13 isolation centers located in different health facilities in the country. These are usually 1 or 2 rooms in a facility that are earmarked to keep suspected cases until confirmation is made. Whilst there would be a team trained in infection prevention and control to take care of these patients. The people put in isolation centers are usually symptomatic and do not on average spend up to 48 hours in these centers. Once the result is out, they are either transferred to the treatment center if it is positive, and if it is negative, they are taken back into the patient pool of that facility to be treated as per their diagnosis. Isolation facilities are in the following centers: Eseo District Hospital, Sibano, the Wek Clinic, Buyam General Hospital, Soma District Hospital, Bansan General Hospital, Carnifing General Hospital, Edward Francis Small Teaching Hospital, Basse District Hospital, Farafenni General Hospital, Brikama District Hospital, Kaur Major Health Center, Fajikunda Health Center, and Bundung Maternal and Child Health Hospital. Some of these are earmarked for renovation and expansion, but they are presently usable. Treatment centers, those are the centers where after isolation, the patients that have tested positive will be taken to the treatment centers. In general, there are going to be 14 treatment centers. 14 treatment centers will be functional for the response. The following are the ones available and ready at present. The one at Sanatorium, that's for West Coast Health Region 1. The Deban Clinic, the first phase is ready and has 14 beds. Sanatorium has 42 beds. Now, Deban, these are all in West Coast Health Region 1. MRC Fajara equally has 30 beds for treatment. However, their main, the wards are available as well if there is a surge. That is 42 beds as well. The following facilities are either under renovation or construction. Sukuta, that's for Western Region 1. MRC Keneba and the Basse sites. Kafuta, the second phase of the Deban Clinic. Soma, Kanuma, Njabakunda, Wasu Palang, Bansang General Hospital, Palang itself, Basse facility, and Yorubaol. These are all going to get treatment centers. The idea is to have at least one treatment facility in each health region to avoid movement of patients and thus lessen the risk of drivers, the risk to the drivers and the staff. The criteria used for selection of treatment centers include accessibility to the road, access to water and electricity, proximity to a major health facility for laboratory support, and the possibility of getting accommodation for the staff who are going to be involved in the treatment of these patients. Procurement of equipment. At present, we have now gotten 20 ventilators, Honorable. We've gotten more since after your tour. We've gotten 20 ventilators now that are ready to be used as and when we need them. The procurement, the equipment that are supposed to be procured include ventilators, X-ray machines, ultrasound machines, patient monitors, ambulances, 33 ambulances. An honorable member asked, the ambulances are supposed to be 33. The procurement process by both the World Bank and the Gambia government will soon be completed, and the equipment will soon be here. The government has asked the Turkish government to help airlift these items free of charge to this country, and it is to the tune of $12 million US. It is believed that the pandemic could worsen in Africa, and the problem is that most of our health systems are weak. So we thought this is an opportunity to strengthen our health systems so that they are robust enough to deal with the COVID pandemic as well as the thereafter. Projections. At the beginning of the pandemic in the Gambia, the projections on the disease were that we will have a total of 181,000 infections at the peak, and we'll be having 3,300 per day. But with social distancing, we were expecting 53,000 infections, and that's at the peak, and 1,000 infections per day. This was a similar projection by the WHO, and the London School of Hygiene and Tropical Medicine. Now, there was another projection by the Policy Analysis Unit of the President's Office, which showed 74 to 93% of the population might be affected. The peak was initially expected on the 17th May 2020. However, it will interest the honorable members to know that, in fact, the picture is gloomier. The new projections have been made based on new data and the spread of the disease so far in the African countries and what we have learned about the disease so far. It is now projected that without any social distancing, we are now expecting a total of 300,000 cases in a period of 300 days. That is, it spreads, that's the estimate for the 1 year. But when it peaks, we expect to have 3,000 cases per day, and at the peak, there will be 10,000 active cases in this country. But with strict social distancing, with the assumption that there will be reduction in contact by 50%, we would expect a total of 1,600 cases in 300 days. So see the drastic reduction from 300,000 to 1,600 with strict social distancing. And a total of 30 active cases per day at the peak, and we would expect 6 to 7 new cases to be registered per day, adding on to the total number of active cases, of course, while some are withdrawn from the total number of active cases because they would have recovered. The peak expected again, now from the projections, we are saying from the first case without social distancing, the peak would have been on the 25th. Now, with some social distancing, we expect the new peak to be around the 24th of June 2020. This shows that most likely the initial social distancing observed by the population has shown dividend, as the peak has moved from its original date of 17th May. This will allow a flattened curve and allow care of the patients, and the patients hope to get better with this when the curve is flattened rather than spiking up. Staff protection. Madam Speaker, distinguished honorable members, as we speak, we have adequate number of face masks, gloves, goggles, shields, shoe covers, overalls for the people who work in the health facilities. Yes, we agree, sometimes there are logistic challenges, and sometimes the slow flow of information. And sometimes people taking ownership is lacking. When these items are finished at some sites, they fold their arms and expect them to be flown to them, rather than being proactive to make the request before it even gets finished. This is the typical attitude, so I'm not surprised that you went to some centers, they say we don't have. And the question to them is, what did you do when you didn't have? Because I'm informing you that we have enough of these items for the protection of our staff. Equally speaking, we equally have been supplying the security forces. It was not in a very well coordinated manner initially, because they used to give to one person who was supposed to deliver it. But we realized that there were logistic challenges, and the Interior Minister promised to identify a focal point who will do the collection and get it to all the people, and he has done that now. So that will also be lessened now. Staff honoraria. The issue of the staff honoraria is yet to be finalized. Distinguished Speaker, distinguished National Assembly members, COVID-19 period is a very difficult period for everybody in the world, for all of us, especially in developing countries. It is very tasking for the population, but more so for the health workers. I will tell you, and more so for the health ministers, but I think it is most difficult for the health minister of the Republic of the Gambia, because the Gambia is a special case. So instead of us to deal with the response to COVID-19, strategizing, develop the policies, we deal with allowances and the allowance list and this and that and that. The Gambia is unique in the sense that things that ministers are not supposed to be dealing with just come to the bear, and if you don't deal with it, there is disaster. So you end up having to deal with that. This allowance issue is very unfortunate. Government came up with the idea that, and as we've been saying ever since, no one can ever pay health workers enough, especially frontline health workers. When people are sleeping, when people are doing other things, when people are enjoying, celebrating, these frontliners are at front there, risking their lives to provide health care for our people. But government said, let's give them honoraria, just a token to say thank you very much. Now, this honoraria, we said, provide us with the list of the people who are at the front line. The problem started, unfortunately, especially when the 500 million was announced. That's when our problem as a health ministry started. Unfortunately, people start to even forget about COVID. All they talk about is money, money, money. That's why I said our work is very, very difficult. Now, we say provide the list. When we talk about these things, it is not the majority, it's just in the minority that do some of these things. The majority are hardworking, dedicated, sacrificing their lives for the people of this country. Now, that minority provided a list. In fact, when you look at the list and the estimates, it consumed almost the entire $500 million for allowances. That was the suggestion. Of course, we wouldn't accept that. We said to them, it's a non-starter. It went back. They brought another list. That list was so big. We say, where are these people? I said, okay, if this list is big, bring it, let us have a look. We looked at the list. There were names of over 300 volunteers. Nobody knows where those volunteers. That means they are not working in the health sector, so if they are volunteers. Now that also went. We said non-starter again. Remove all the volunteers. Bring the list of the core people. The list of the core people was brought. Some people came together to say, we know the people who are the active players. That list came. We saw names appearing in one section and another and another and another. Then I said, no again. Took the list back. Then we went to Kotu. That's where our central operations are. That day, as health minister, I stayed with the team to project, because we wanted to give some of them something, because you all had their complaints. It was difficult for them. Sometimes they leave home early, they don't go home early. So we said, let's mobilize quickly to give them something. But we need a list. Now, we looked at the list. I was there with them. They projected the names till 2 a.m. in the morning. I don't think any health minister does that in the world. That's not my responsibility. But if I don't do that, what will follow is disaster. Now, we looked at it. As we looked at it, we realized that they had various duplications. That night alone, 300 names were removed. Why were they removed? Because you will see some names at some point, and so many names. Then we say, okay, you have the team leaders here. Team this, team that, team this. When we project it, if these are in your team, you say yes because you know them. Look at your own list. But you also equally take responsibility because you are here and you say these are, oh, then you start saying, I don't know that one. I've never seen this one. Who put this name? Now, this is what we do. So we went down there. I say, since there are various groups, let us now arrange them alphabetically. So that when the groups are there, you arrange the groups you arrange all the names, ignoring the groups alphabetically. Then you see one name 3 times, 4 times, 6 times. Then we had to remove it. These are the challenges that we faced. Now, when we streamlined the list, we now said each one should get paid 5,000 honorarium. When that was met, they started. Then some started saying they were not involved, these ones are not involved. But the initial one was to pay the frontliners first. And the frontliner definition was those who were in the contact tracing, the surveillance, the laboratory, the case management team, and just in the health facilities, case management team, the people at the accident and emergency wards, and the people who are also at the outpatient units, because accident and emergency and outpatient are the people who receive any patient coming into a health facility. When they come and they suspect COVID, they alert the case management team in that facility. So this we regarded as frontliners. Now, so this is what delayed the list. Now we said compile the list now. Some payments started, but that was a limited number. That is why the others couldn't get paid. Because now they started wrangling, and some people from some facilities were putting in their friends, their relatives, to be in that frontliner. So even to get those frontliners. But we said, let's get the frontliners paid first so that the rest of the people will also get paid. Probably a little less, because we have to stratify. Because if we don't stratify, the person who goes to take a sample from a patient, he's more at risk. But a person who is sitting down in the health facility is also at some risk. But you cannot compare them with this. If you make it flat, the person who goes to follow the patients will be complaining. He will say, oh, I'm risking my life.